Great. Okay, so I was asked in this session to actually not look too far forward, but look at what our current treatments are. And I think the term best available treatments came into the title because actually nowadays, in terms of clinical trials that we've done, especially thinking about the newer trials with ruxolitinib, we've called the control arm treatment best available treatment. So I think that's a bit of a odd phrase, and it sounds a bit kind of second rate, actually. So I wanted to just spend a few moments just talking about that. Because ultimately what we're trying to do when we're selecting a treatment with a patient is we're trying to select a treatment that is tailored for that person as an individual, collectively with knowing what we know about the disease, but thinking about the person as an individual and choosing what is the best available treatment amongst all of our therapeutic options. So outside of a clinical trial, the best available treatment for a patient might actually be to see, is there a clinical trial for them? But otherwise, it's what is available in our countries, which brings me on to the second point I wanted to make. And just a comment, if I may, about some aspects that I think are important in the word advocacy, which is actually about advocating for patients as a voice for patients in terms of making sure that appropriate treatments are available for them where reasonable within their own country. And I'm particularly aware of that with regard to novel treatments such as ruxolitinib, but also with regard to treatments such as transplantation. Not all of us have such ready access to transplantation. There are guidelines that will guide health physicians in terms of selecting which treatment to use for their patient, and these are now widely available. They have a number of utilities other than standardising treatment. They're also important for education. They can lead to better use of health resource if, for example, experts in the field feel comfortable that their patients only come every 4 to 6 months if they're stable on hydroxyurea. A doctor that doesn't see so many patients may not be so comfortable with that, so it may actually help them to design their practice even in terms of simple terms like that. May be important for getting agents funded and can be important in terms of defining endpoints for clinical trials, and I'm sure that patients also access these guidelines. So I just put some examples, and in fact in the UK our guidelines are co-written with MPN Voice and MPN Voice representation. So as we've heard so many times in clinical talks in this meeting, we're thinking about assessing risk and treatment targets for our patients. We have to think about a number of different events in terms of targets, and in the middle of here should appear something about symptoms, but I don't think it's going to appear. I think it's a different version. So let's think first of all about the main target, which is about stopping blood clotting. This is a very beautiful picture, I think. This is an electron micrograph of platelets. So far you've seen platelets as little pinky purple blobs, but actually platelets are highly active. They can extend these little probes, if you like, from their membrane, and they stick together. And this is the root cause of a lot of the problems that patients with MPN have. Either platelets sticking together or platelets sticking to white cells, or white cells doing the same thing and sticking to the lining of blood vessels. So a lot of our management is tailored on stopping the platelets sticking together, but also about stopping standard things and thinking about standard things in preventing atherosclerosis. So this is a slide I've used for a long time. Really important to be fit. I can't do that. But really important, I think it's a massive success for our team if I stop a patient smoking. Thinking about statins, blood pressure, etc. is something the haematologist may not be comfortable with doing, but that's part of a conversation with the primary care physician, for example. And then the knowledge gap about, well, what is an MPN? Why is a blood cancer a problem for blood clotting? Why do you want to give this patient a cholesterol when actually I wouldn't otherwise? It's an interesting and frequent conversation. So let's think about the different entities individually. You've seen this slide already. This is about PV. So what do we do when we're treating PV. You've seen a similar version of this slide, but I'm telling you now that when we divide patients up into low risk or high risk, so low risk patients would be aged less than 60 and no vascular event, both the ELN, European Leukemia Net UK, ESMO and French guidelines and many others would say low dose aspirin and phlebotomy, target hematocrit 0.45, sometimes lower. Some clinicians go lower for women. We, in our practice, sometimes go lower if the patient has symptoms with a hematocrit of 0.45, and we would always go lower for patients who have had a splanchnic abdominal vein thrombosis. And for high-risk patients, we would add some of the drugs we were talking about this morning. So bloodletting or phlebotomy is a very, very old-fashioned treatment in medicine, and it's a treatment which is the cornerstone of PV, but it can be a very difficult treatment for patients to manage. We talked about logistics of time. We haven't talked much about iron deficiency, which is what phlebotomy causes, and the associated problems with that, such as restless leg syndrome and worsening fatigue. How do we know how thin to make the blood? So this is actually Tony Green's blood. Tony Green is a very eminent scientist and clinician in this field and a great friend and colleague of mine from the UK. This is a slide he made with his blood to illustrate what is the hematocrit. So it's the amount of red cells in the blood. And we know that 0.45 should be a target from a study called the CYTO-PV study, which was performed in Italy. Ironically, this study had to be stopped early because patients were being recruited into trials with JAK inhibitors. But this study actually has answered a very basic question that was an open question in the field. Yes, the target should be 0.45, because if you run slightly above that, i.e. 0.45 to 0.5, which many haematologists continue to do, the risk of a vascular event is, you can do the maths even after lunch, 4 times higher. So really very important. Right. So how else might we identify high-risk PV, and what other things might we think about? So we might think about the white cell count. Some of us measure the JAK2 amount of the JAK2. That's not often done in clinical practice. And there's some interest in inflammation. Hans Hasselbach, another eminent clinician in this field, is a strong advocate of the role of inflammation in this disease. And so there are things that we can measure for that. But going back to the blood count, is the platelet count important? Well, the data from CYTO-PV suggests the platelet count is not important. So if you compare the two arms, low hematocrit arm, there's the red. Here, that's the middle of that. That's the upper quartile. And here's the high hematocrit arm. They're pretty much mapped. There was no difference in the platelet counts between these two arms, suggesting, if you look at the results from this study, that the platelet count is not important for thrombosis in PV. On the other hand, the white cell count may well be, because these two curves are actually very different. And more recently, there's been a publication suggesting that a threshold of 11, above that threshold, we should be concerned. So that's why when I was showing you those clinical scenarios earlier, those are the things that we were asking. White count more than 20, definitely a concern for me, but not well embedded in clinical practice. One of the big questions in our field is this issue and an ongoing dogma about should it be hydroxyurea or hydroxycarbamide, or should it be interferon? Interferon, as you will know, has many advantages. It may well reduce the clone, so the JAK allele burden can go down. Patients can have a clinical remission with a long gap on therapy, or be on a tiny, tiny dose for a very long time. There's a question mark about whether it really truly reduces vascular events, although some folk, for example Dick Silver, will say, I've not had a patient had a clot on interferon, some of us have. The real question is, can it alter the natural history of the disease? Can it hold back that other target progression? So there are some suggestions that it might. So here's some bone marrows. I won't test you, but basically these are bone marrows during the course of treatment with interferon, published by the Swedish group, showing more normalization. So you can appreciate that megakaryocyte is smaller and without so many close cousins near to it. So it looks like not only do the blood counts get controlled, do the amount of abnormal genes go down, but the bone marrow may be changing too. But there are disadvantages of interferon, as many of you may also know. And we don't have real studies comparing interferon with standard therapy. We don't have the results from them yet, but there are several ongoing in the field, and at the forthcoming American Society meeting, results from this study and this study will be presented. So we hope to see some real data. One of the problems, though, is this problem about injecting for some patients. Some patients really cannot do needle injections. They're very phobic and they really don't like it. So it is a problem. Yvonne's going to talk to you about side effects. Hydroxyurea, well, I probably don't need to tell many of you about this drug. It's by far the most commonly used drug in this field. We had a best practice alert for prescribing oral chemotherapy in the UK. Hydroxyurea was by far the most common drug. There were over 10 million prescriptions for that drug in 1 year in the UK. Not only is it used for MPN, it's also used, for example, for adults with sickle, but it is a very commonly used drug. Yet, we have this unanswered question: might it cause leukemia? And as I was talking to some people over coffee earlier on today, well, we know it's a ribonuclease reductase inhibitor, but actually what does it do? Why does it work in MPN? And therefore, understanding some toxicity, we don't really have a handle on that. So I actually have a student starting soon in our lab to collecting some of this data and trying to help us work that out. We also are beginning to understand that hydroxyurea resistance or intolerance is a problem for patients. And increasingly, these are patients that we're selecting to test new agents such as ruxolitinib and others. But there is a problem in that physicians and patients do not recognise these criteria that are published and in the public domain. They don't recognise so well that if a patient is still needing a lot of phlebotomies, like we said this morning, they need a change of therapy. If the patient's white count is still high, they need a change of therapy or at least a discussion. Intolerance, such as mouth ulcers, leg ulcers, you'd think that would be well known, but actually there are a lot of patients that come to clinic who perhaps won't bother telling us they've got a leg ulcer and may not tell us they've got a mouth ulcer either. So there's a lot of patient education and also physician education that's really important on that topic. Also, there's another problem with these guidelines in that they talk about a maximum dose of hydroxyurea of 2 grams per day. So the perception in the clinical field is I have to get my patient to 2 grams a day before I can call them resistant or intolerant. And actually that's really practically not something that we would do in standard practice. And so some of us have proposed something called the maximum tolerated dose for patients, which basically means you can take a patient as far as you think they'll be able to manage, and then you can say, okay, the patient meets the criteria. There are many second-line options for patients. Hydroxyurea, if you've had interferon and vice versa. Then there are older drugs such as busulfan, or pipabroman is used in continental Europe, less so now because it and radioactive phosphorus are clearly leukemogenic. But busulfan is an incredibly useful drug for patients who find it hard to regularly take drugs. It can be given in a variety of different ways, but the clinical community are not very familiar with that drug. So increasingly, there have been a few publications in the last year, and one nice one from Carlos again, and one from ourselves in collaboration with the Australians with regard to its utility. The JAK inhibitors obviously been tested and approved and available in some countries second line, and then other experimental therapies such as histone deacetylase inhibitors. This is what my parents thought I was doing when I did my PhD. So I'm sorry if you find it kind of maybe a bit difficult as a concept, but I was a child in the 70s, and this is what they think ET is. So ET is very similar to PV, very similar what else might be important, although we have to think about this calreticulin mutation and that this might be a milder disease. We also have to do this thing about differentiating ET from myelofibrosis. By the way, I think that's also a difficult interface for PV as well. In ET, we completed a very large study in the UK comparing hydroxyurea and anagrelide, and this data comes from 22,000 blood counts, showing that once the white count goes just at the upper limit of normal, there is a clear relationship between the white count and the occurrence of thrombosis, and also bleeding, but the same is not true for platelets. There's also an open question about whether aspirin is really a best treatment for ET, and that is because of some data that's come from Carlos and a collaboration across Europe. So here in this analysis of 300 patients from the Spanish registry, and these patients were low risk ET patients, they were variably treated by their clinicians, so it wasn't a randomized study. There were 32 thrombotic events. In 15 patients who 15 patients who did not receive an antiplatelet drug and 17 who did. One so-called low-risk patient died of a thrombosis, so it's not completely absence of risk, it is low risk. And interestingly, after 9 years, there were no events. Further data suggested that aspirin protected patients who had cardiovascular risk factors, so smokers, high blood pressure, etc., and might protect JAK2 positive patients against venous thrombosis. And this story of increased bleeding on aspirin came out also from this study. More recently, across Europe, using the European Hematology Association working group chaired by myself and Jean-Jacques, we did a retrospective analysis of low-risk patients who had the CALR mutation, and we found that, again, that aspirin benefited JAK2 positive low-risk PV patients. We saw less thrombosis for the patients that were on aspirin versus observation. So aspirin is the dark black box here. But this is not true for CALR patients. And the CALR patients also had more bleeding when they were on aspirin. So this is now raising a real important practice decision. So drug choices for ET, interferon or hydroxyurea, very familiar question. And then the question about this drug, anagrelide. There have been now several studies assessing anagrelide in ET. There are some differences in outcomes when large numbers of patients are compared. The British study showed anagrelide was not as good at protecting against arterial events, bleeding, and there was more fibrotic transformation. A smaller study performed in Austria, Czechoslovakia, showed that there wasn't a difference. Second-line choices are very similar, but ruxolitinib is regarded as experimental for ET. So in summary, for these two disorders, challenges remain in determining who will need cytoreductive therapy. It's likely that mutational subtype and leukocyte count will be incorporated in future versions of practice guidelines, and there are some new practice guidelines that we're going to start working on at ASH. Aspirin is not a panacea, especially not for CALR positive PV. And we still have this debate about interferon versus hydroxycarbamide. But truly, as I tell my patients, it's about individualizing for you. Try the one you think will suit you best. If it doesn't, we can switch to something else. For myelofibrosis, you're well aware of this picture. I told you it gets used a lot. Jack, the decision about transplantation is a really big one, and you've got the world expert coming to speak to you after me. There's a question about intermediate 1 risk symptomatic patients and their access to ruxolitinib. It's not widely available in that context, certainly not in the UK. NICE has only approved it for intermediate 2 and high risk. Symptom scoring, this was my slide originally, I think. And then lots of open questions. Should we use JAK inhibitors in low-risk patients who've got high-risk mutations? There's a study starting for that. How should we decide if a patient's failing a JAK inhibitor, and what should we do? And what should we do with low-risk asymptomatic myelofibrosis? Well, that might be what should we do with prefibrotic myelofibrosis as well. Some people would use interferon in that setting. You already saw this, so I'm going to move swiftly over it. The data with ruxolitinib has been very important because it's profoundly affected patients' lives. But it's also shown us the relevance of the spleen. So I was really pleased to see Ruben discuss the spleen. So in this analysis from the COMFORT studies, we were able to show that if a patient gets any spleen reduction at 24 weeks, they did get a survival benefit. So survival benefit was not what we were expecting to see with ruxolitinib. We did see it. It's a little bit contentious, although increasingly most of us are very firmly convinced, myself included, and this data regarding the spleen is important. With regard to how to use JAK inhibitors, the British guidelines are very pragmatic. There's this conference meeting to decide. We would say ruxolitinib is a first-line therapy for spleen or symptoms, but the target would be individual for the patient. There's a lot of lack of experience in use of JAK inhibitors and dosing, and we proposed a kind of traffic light thing for when you should consider stopping. Resistance and intolerance are words that come up with regard to JAK inhibitors, and they are a little bit more difficult to handle than agents such as interferon and hydroxyurea. We have to think about infections and we have to think about weight gain. That's my summary slide for myelofibrosis, and I know my time's up, so I think I'll stop on that one. Thank you.